I hope you are able to see the PPT now. Partogram is a very, very important topic, both from the point of exams as well as practical point of view, because it is a very important, simple, inexpensive tool which will prevent a maternal death. Obstructed labor and ruptured uterus contribute up to 50% of maternal mortality, and that is not at all acceptable in modern obstetrics. Early detection of abnormal progress and prevention of prolonged labor can significantly reduce maternal mortality. So it's very clear that we have to monitor the progress of labor and detect the early slowing down or detect whether the patient is heading towards obstructed labor, so that we can take timely action and reduce maternal mortality. Before we go further, let's look at the magnitude of maternal mortality worldwide. Every day, 800 parturient women die worldwide, and developing countries account 99% of it. Two regions, Sub-Saharan Africa and South Asia, account for 85% of global maternal deaths. India, it has come down thankfully to 120 deaths per 100,000 live births, but it is not uniform in all the states. Some states still have 300 deaths per 100,000 live births. So it is unacceptable. We have to improve ourselves. The only way is a proper monitoring of the labor, and that is possible with Partograph. The obstructed labor is a major obstetric burden. About 8% of all maternal deaths are estimated to be due to obstructed labor. It's a leading cause of ruptured uterus, vesicovaginal fistula, maternal dehydration, infection, ketosis. All of them can lead to maternal death. It's also associated with increased incidence of fetal hypoxia, birth injuries, and even fetal death. What are the measures taken to reduce complications due to obstructed labor? Clinical pelvimetry to assess CPD is very, very important. I always stress that it is always prudent to rule out CPD. And if there is CPD, the patient is well off with an elective cesarean section. However, there are few obstetricians who believe that it is not possible to do clinical pelvimetry before the patient goes into labor, and it is better to assess them in labor. Well, that is sometimes maybe too late. That's what I would like to say. It is always prudent to rule out CPD and take the patient for elective cesarean section if you have any doubt. Only in borderline CPD cases can you can allow the trial of labor. That's topic for another day. I'm not going to elaborate on that today. Ultrasound estimation of BPD and fetal weight is a very, very important step. Nowadays, most of the labor rooms have ultrasound machine, and you can assess the fetal weight to the accuracy of around plus or minus 8%, 8 to 10%. The heavier the baby, of course, the difference is larger, but otherwise it is possible. And you can do an ultrasound assessment of CPD as well, but you require a lot of calculations there. Even MRI has been used sometimes to rule out CPD, but that is not done only in the research setup. X-ray pelvimetry is gone forever. We never do that. Using principles of trial of labor in borderline CPD is an important step in prevention of rupture uterus, but that's again for another day. Appropriate operative interventions whenever need arises, maybe a vacuum delivery or a forceps delivery, or even an emergency cesarean section, will go a long way in preventing the maternal mortality due to rupture uterus, which in turn is due to obstructed labor. So incorporating Partograph in the management of labor is a very, very crucial and pivotal step, and that's been advised by WHO. What is a partogram? It's a graphical representation of first stage events in a single pre-printed format. Please note here, it only represents first stage events. Till today, there is no partogram for second stage of labor. All events are pictorially represented on the time axis so that you know if there is a delay or if there is a hurried up or precipitate labor. It mainly focuses on two things. Number one is cervical dilatation. Number two is descent of the head. Obviously, these two are the most important part of the labor. Progress of labor can be assessed at a glance when you use this partogram. Even a non-doctor, trained nurse, or a trained birth attendant can use this very effectively. And at a glance, a senior doctor can make out that the labor is not on track. When used effectively, it provides a graphic representation of progress of labor and the condition of the mother and fetus. So you get all the information. It helps in early detection of prolonged or obstructed labor. It's always prudent to diagnose prolonged labor so that you don't allow her to go into obstructed labor, which may end up in rupture uterus before you could take action. It guides in decision making in the management. That is the partogram. Let's go a little bit into history of it. The development of partogram. Friedman was the first person who did enormous work as early as 1954. We all know that Friedman's curve. I'm going to briefly talk about that in the next slide. Then so many people did their work, but it is Philpot in 1972 who actually contributed a lot. And today's partogram is a modified version of Philpot's partogram. Indians also have contributed, and even CMC Vellore has come up with its own partogram. But I'm not going to talk about that today because that's not universally followed. What is Friedman's curve? Plotting cervical dilatation against time yielded the typical sigmoid or S-shaped curve, and station against time gave rise to the hyperbolic curve. This is the picture which you can see in all undergraduate, even postgraduate textbooks. As you can see here, initially it's a prolonged latent phase, and then suddenly in the active phase, there's a sharp rise, and then there is a plateau. That is the S-shaped curve we are talking about. As far as the fetal head descent is concerned, initially there is not much happening, but later in labor, there is a sharp descent of the head. This was good for a long time, but this has got its own problems. What are the problems? The time of onset of labor was based on patient's subjective perception of her contractility. So it is very, very difficult to monitor that. No exclusions were made for malpresentations, malpositions, or multiple pregnancies. It did not include other parameters like fetal heart rate, contractions, amniotic fluid, maternal vitals, etc. Women receiving caudal analgesia, oxytocin infusions, and operative deliveries were included. That would complicate the issue. Then the stud paper came in. These are the fixed stencils. He has already given 5 areas, and you have to plot in this, but it has got its own problems. These stencils predicted the expected pattern of progress. 5 separate patterns were made and transcribed onto acrylic stencils. Those crossing the normogram line were found to have 3-fold increase in instrumental delivery. But this does not again represent much, so it was not used more. As I said earlier, it is the Philpot's partograph which was highly developed. The main use was to fulfill the need of paramedical personnel. As I said, partogram can be used by non-doctors also. He introduced the concept of alert and action lines. The alert line represented the mean rate of progress of the slowest 10% of patients in the African population when he developed it. The action line was drawn in the original Philpot Partograph 2 hours to the right of the alert line. But this has changed now. WHO took some initiation, and as a part of Safe Motherhood Initiative, it decided to rigorously evaluate Philpot's reports, and a large trial was conducted in Southeast Asia involving 35,484 women in 1984. The hospitals in Indonesia, Malaysia, Thailand were selected randomly for the purpose of the study. Incidentally, I was in Malaysia at that time, and I was also a part of this particular study. Salient points of initial WHO partogram were: the latent phase was up to 8 hours. Active phase started at 3 centimeters. They included the descent of the head. Alert and action lines now, instead of 2 hours, were 4 hours apart. But then the WHO recognized there was a need for modification, and modified Philpot partogram is the one which now we are using. Doesn't have latent phase. It was removed in year 2000, because latent phase is one indefinite time. Sometimes it can be 6 hours, 8 hours, 12 hours, 24 hours. We can't be sitting and plotting the partogram. So latent phase was removed in 2000. Active phase, instead of 3 centimeters, it started at 4 centimeters. Of course, there is another entire now new thinking, which says that active phase starts at 6 centimeters. You must have heard lectures that 6 centimeters is new active phase or new 4 centimeters. But I want to clarify right away that is not yet accepted by WHO. So we are still using this 4 centimeter as the starting point. Descent of the head was recorded by abdominal examination instead of the pervaginal examination. Now it became a little easy. So this is the modified WHO partogram that all of us are using right now. I'm going to talk about each component of them in detail. Now that you have seen entire WHO partogram, let's go to individual things. Before that, role of partogram in the management of labor. It helps us in early detection of abnormal progress of labor. That's what precisely we wanted. It prevents prolonged labor so as to prevent the obstructed labor. It recognizes the CPD long before obstructed labor. Of course, how it recognizes, we have to, of course, reassess. I will tell you when to reassess. It assists us in early decision on transfer from a primary care center to a secondary or a tertiary care center where cesarean delivery is possible. It also helps us in taking a decision whether to just augment or to just stop the labor and take her for emergency cesarean section. Let's examine that in individual. The first part of the partogram is the patient information. Probably this is the easiest part. You have to write the name, gravida, para, hospital number, date of admission, time of admission, whether the membranes were ruptured at the time of admission or not. If ruptured, since how many hours it is ruptured. Very simple, straightforward. The other major components are fetal heart rate. I will elaborate on each one of them. Second one is liquor and moulding. Then comes the most important part, cervical dilatation and descent of the head. Then you have uterine contractions, oxytocin and others if used, maternal condition, a complete plotting of the maternal condition. Let's go to the fetal heart rate part. What are the rules? You should check this every 15 minutes if you are doing intermittent auscultation in the first stage of labor. If you are doing continuous fetal monitoring, that's another matter, but that also has to be reviewed every 15 minutes. You must count for full 1 minute after cessation of the contraction. I will tell you this in another class when I take class on fetal monitoring during labor. Why you cannot just count for 15 seconds and multiply it by 4. All of you know that there is something called beat-to-beat variability. If abnormal, we must repeat the counting after 15 minutes and take a call. If there are 3 abnormal heart rate patterns, a decision for cesarean section or an instrumented delivery should be taken. All of you know that in second stage, we check the fetal heart rate once in 5 minutes. I was talking about first stage here because the partogram is useful only in first stage. Till today, there is no second stage partogram. So I was not talking about checking the fetal heart rate in second stage. All of you know that the normal heart rate is 110 to 160. Anything more than 160 is tachycardia. Anything less than 110 is bradycardia. Now, we should not wait for it to go below the normal. We should look at it as and when it goes above or below normal heart rate. The next part of the partogram is the indication of status of the membranes and their significance. If the membranes are intact at the time of admission, you have to write it as I. If it was ruptured, the liquor is clear, you must mention it as C, clear liquor. If it is meconium stained liquor, you must write it. And also you must write whether it is thick meconium or thin meconium. If there is any blood, maybe you are dealing with a case of abruption or a placenta previa, you must write blood stained fluid. If it is totally absent liquor, you must write A. So as you can see here, MBA is very dangerous. MBBS is okay. MBA, we have to be alerted. As far as moulding is concerned, the second line, if there is no moulding at all, you should write 0. If there is just approximation of the sutures opposed to each other, then it is 1 plus. If the sutures overlap, but when you press, you can still reduce it, then it is 2 plus. If the sutures are overlapped, and you cannot reduce them, you must write 3 plus. This is pathological moulding. That means there is a CPD. If not at the inlet, maybe at the mid pelvic level, which is rare, but still it is possible. A good doctor, a prudent doctor, will take her up for section at this stage, will not allow the labor to progress any further. Difficult to assess the moulding if there is a large caput. A large caput itself suggests that there is probably obstructed labor. Now I come to the all-important part of the partogram, that is the cervical dilatation and descent of the head. Now the cervical dilatation, all of us know, happens at a particular speed. Based on that, they have drawn 2 lines. One is called alert line, the other one is action line. The alert line is drawn on the basis of the cervical dilatation happening 1 centimeter per hour after the active phase, which is deemed to be at 4 centimeters. As you can see here, each big box is 1 hour, from 0, 1 hour, 2 hours, 3 hours, 4, and 5, like that. As you can see here, at 0 hour, it is 4 centimeters dilated. 0 hour is not the hour when the patient came as such. It is when the cervix is 4 centimeters. This has to be understood very clearly. After 1 hour, it becomes 5 centimeters. After 2 hours, it is 6. After 3, it is 7. After 4, it is 8. After 5 hours, it is 9. And after 6 hours, it is 10. So it is 1 centimeter per hour after 4 centimeters. And the action line is drawn just 4 hours to the right of alert line. That means, suppose the labor progress or the line that you are drawing crosses the alert line, you are alerted that there could be some problem. You have to reassess. But then if it crosses the action line, you have to take action. What is the action? If the patient is not fully dilated yet, even in second stage, sometimes you may take her up for emergency cesarean section. That is the action. That's what we expect. Only if the cervix is fully dilated, head is there on the perineum, then probably you can use a forceps or a vacuum. Otherwise, the action most of the time is an immediate or emergency cesarean section. I hope it is very clear. The action line can be less than 4 hours, depending upon the center or depending upon your experience. For example, if you are in a peripheral hospital, you don't wait for 4 hours and then send the patient to the higher center. Probably in your particular center, you can say my action line is after 2 hours or after 3 hours. That means the action may not be cesarean section because you don't have the facility for cesarean section. The action that you would take is transfer the patient to a higher center. So there, the action line may be slightly earlier than 4 hours. What is depicted here is the action line in the best of the centers. Even there, depending upon your previous experience, you may not wait for 4 hours after there is an alert. I hope I am very clear about it. The rates of cervical dilatation and the descent of the head in primi and multigravida slightly vary, as you know. In active phase primi gravida, actually, the cervical dilatation is 1.2 centimeter per hour, but WHO considers at least 1 centimeter. WHO is always more generous. In multigravida, it is faster, that is 1.5 centimeter per hour. Accordingly, you know that the active phase will be shorter. As far as the descent of the head is concerned, in primi gravida, it is 1 centimeter per hour is the descent. And in multigravida, it is 2 centimeter per hour descent. That's why the labor is slightly faster there. When to start the plotting and how often to plot and when to stop are the usual questions that come to us. 0 hour begins at 4 centimeters. This I have told you very clear, not the time of admission of the patient. You don't start plotting when the patient is admitted unless she's already 4 centimeters and more. I will tell you what to do when she's more in the next slide. But you start plotting when she's 4 centimeters dilated. Per-vaginal examination is repeated every 4 hours once the labor is well established. And then once in 4 hours, you plot it. It may be more frequent when the problems require an early decision. Cervical dilatation is constructed starting at 0 time and ends at 10 centimeter dilatation. Very, very easy and clear. Now, in a normal labor, as you can see here, 0 hours started at 4 centimeters. Maybe after 1 hour, she is 6 centimeters dilated. And after 2 hours, she's 8 centimeters dilated. And after 3 hours, she is 9. And after 4 hours, she is 10 centimeters. This is slightly faster labor, as you can see here. Otherwise, alert line is usually after 6 hours of 4 centimeter dilatation. This is okay. This is normal labor. Cervical dilatation here is not crossing the alert line, and we are happy. The most important question is how to plot if the patient reports at 5 centimeters. That means when the patient has come to the hospital, she's already 5 centimeters dilated. Let's say she came at 8 a.m. in the morning and she's 5 centimeters dilated. If you plot it there, considering this as the 0 hour, and then let's say after 4 hours you do a PV and she's just 8 centimeters, if you see here, the line of labor is to the left of the alert line. It has not crossed the alert line. But actually, you know that 3 centimeter dilatation in 4 hours is actually slow dilatation. It's going towards prolonged labor, but it has not crossed the alert line. It is wrong. This is not the way to plot. How to plot then? When she came to the hospital, if she was 5 centimeters, don't put it at 0. Transfer it. Because after 1 hour, she becomes 5 centimeters. When you do that, let's see the same thing. After 4 hours, she is 8 centimeters. Now, can you see it has crossed the alert line? And you are alerted. So 3 centimeters in 4 hours is slow dilatation. And in this way, it has crossed the alert line also. I hope you are very clear about it. This is the correct way to plot. How to plot if there is only one finding? Many of our undergraduate students tell me that, sir, by the time patient came, she was already 8 centimeters. They didn't do second PV, which should have been done at 4 o'clock, and she delivered. When she delivered, it automatically means she was 10 centimeters. We know that you just need 2 points. The first finding when she came, let's say she was 8 centimeters, and the time, second point you get, that is 10 centimeters, which is the full cervical dilatation, roughly minus 1 hour from the time of delivery in primigravida and 1.5 delivers in multigravida. We all know this, the duration of second stage. So from the time of delivery, minus 1 hour gives you when she was 10 centimeters. You already know at the time of admission how many centimeters she was. So even if there was one PV, you can still manage to draw a partogram retrospectively. All of you know about Crichton's method. This is the abdominal examination to know the descent of the head. I'm not going to elaborate on this. Right. So in PV also, you can find this out, the 4/5, or you can say 0, -1, -2, -3, +1, +2, +3. That also can be done. So how is it plotted? So let's say at the beginning, it was at 0 station, and then later it comes down in 5 hours. This is the way you plot the descent of the head. As far as the uterine contraction is concerned, if the contractions are minimal, less than 20 seconds, this is how you plot. Then you can plot if there are 20 to 40 seconds, but the duration is also noted here. And finally, she has got more than 40 seconds and lasting for at least, 5 boxes can be ticked. So this is how you plot the contractions. As far as other things, whatever you give is noted, IV fluids and other things, and maternal parameters, pulse, BP, temperature is also noted. And this is how the role of Partogram, now we have understood, it can detect fetal distress, it will suggest augmentation, and it will most importantly recognize abnormalities. That's how you can recognize obstructed labor, maternal distress, prevent maternal death. So what are the active phase disorders? Cervical dilatation disorders include protracted active phase, secondary arrest of dilatation, or precipitate labor. As far as descent disorders, protracted descent, arrest of the descent. Let us look at this. Prolonged active phase means right from the beginning, it is slow and it is touching towards action line. Wrong to allow it to go till that level. Whereas secondary arrest means initially it was okay, later it crosses the alert line. So this is the secondary arrest. As far as descent, initially it was okay, later it stops descending. That's how you plot it. So how to manage? If there is a problem, you have to reassess, as I said earlier. What are you reassessing? Abdominally, contractions, descent of the head, fetal heart rate. Per-vaginally, rule out CPD first. As far as head is concerned, assess the station, position, caput, moulding. As far as cervix is concerned, effacement, dilatation, and most importantly, application of the cervix to the head. If it is hanging loose, that means there is CPD. Membranes, present or absent, and what's the color of the LICA? If CPD is present, just do cesarean section, nothing else. If the inertia is present, you can do ARM plus oxytocin to augment the labor. If there is crossing of the action line, ideally it should not be allowed, but if it crosses, not emergency, but immediate cesarean section should be done. As I said, second stage is still under trial. Second stage partogram is yet to come. I have already told you this. Advantages is it is inexpensive. One paper is used. Failure to progress can be assessed easily. Augmentation decision can be taken, and you can recognize obstruction early and go for cesarean section. There are some limitations. It's a tool for managing labor progress only. Does not help in identifying the risk factors. It is only for first stage right now, and assessment of descent beyond 0/5 is not represented here. The PV part is not done. Thank you and bye for now.